It's gonna, oops, hold on, somebody got kicked off. So we're gonna talk about different types of healthcare settings, and healthcare systems that are available here in the United States, which is what chapter 15 is going to be all about. So I don't know who just got kicked off, but all right. So healthcare system in the United States. It is very complex, right? There are lots of different um, organizations that are available. There's public, there's private, there's also voluntary health agencies as well. And if you looked at the PowerPoint for this week's it can look a little kind of, I guess, maybe overwhelming. A lot of different information. I will share my screen so you can see the PowerPoint. All right, hold on. All right. Can't tell who got kicked off, but they're coming back in. All right. So when we look at the different types of healthcare entities that are available, um, we have public, which are government agencies. We also have private entities, which are going to include both your profit and your for-profit and your nonprofit. So this chart is in your text, I believe. And it just kind of outlines the differences between the public and the private healthcare agencies. So I don't know, I need to make this a little bit bigger for myself because, yeah. Um, so with our public, which are our official, we have official, which is your government agencies, and we have our non-official, which are voluntary. So our governmental agencies are supported by tax money. Their primary services are disease prevention and wellness promotion. They sometimes will direct services of healthcare. They are accountable to both the government as well as taxpayers. And the programs are both mandated and non-mandated, which are unofficial or your voluntary. Um, their support is through voluntary contributions and fees for service. Their primary services are research and education. I'm going to break this down even more as we go, but um, they also offer direct healthcare services, and they are responsible or they're accountable to their supporters, to their boards, and their programs are determined by the supporter interest. Your private organizations are fee for service. They're focused on curing disease and illness. Um, and their additional services may be disease prevention and wellness. They're accountable more to their owners, right? Because they're private organizations. And the programs are determined by the defined goals of the organization. So we'll kind of break this down again a little bit more. So again, public healthcare agencies, we have our official, and we have our voluntary. The government programs, again, those are going to be nonprofit. They are tax supported, so they're accountable to the taxpayers as well as the government. Their, primary emphasis is on the delivery of disease prevention and wellness promotion programs. They also may provide some direct healthcare services. Your voluntary or nonprofit, they are supported by voluntary contribution. They charge a fee for services, which a lot of times with the nonprofit or the voluntary, the charges here are often based on the person's financial ability to pay. Um, they are their activities are determined by supporter interests. So it's not legally mandated. The emphasis is on education and research, as well as maybe offering direct healthcare services. So everybody has heard of the public health care or public health department, right? Everybody is, maybe not ever been to the health department, but right there, it is available. So the official health agency at the local level is the city or the county health department. And so these agencies are funded by local tax money. They also may get subsidies from either the state or the federal government. They carry out state laws which are mandated concerning community health. They also may carry out some non-mandated programs like health promotion programs. Anybody know what health promotion programs may be carried out by your local health department? Anybody ever been to their health department, see what they have to offer? I know a lot of people may go get like their vaccines there. Anybody else ever use the health department? No? Okay.
The health department does WIC. It has the WIC program. It does do the immunizations. It does do like HIV screening and stuff like that.
mhm.
Um I just see a lot of the stuff like when they're in the neighborhood setting up doing a lot of community activities as far as getting like I see them dealing with a lot of Spanish people, a lot Puerto Rican people, a lot as far as getting them like free health stuff set up. They try to
Right.
get them set up with like Medicaid and stuff like that. I do see that around my community.
Yeah, so the health department does. Yeah, they do that. They'll work with like your immigrants coming into the United States to help them get set up with services and testing and immunizations and things like that. Very good. Yeah, absolutely. I know back when I was in my bachelor's program, which seems like forever ago, I spent a week at the health department during my community course. Um, and so just kind of working with different people within the health department. So that's how I found out about, the services that they provide to those that are immigrating in. They do like the tuberculosis testing. They, help them get set up with Medicaid and some other resources. Um, what else did I do? They also had at the time, and I mean, this is a long time ago. Um, so they had a diabetic educator as well. And so she would go out and she did home visits to some of the like the newly diagnosed diabetics or some of like the higher risk. And she would do like just follow-up visits with them. Um, but another really cool thing, we talk about health promotion programs. One of the things that our health department had was it was the Medical Reserve Corps. And I'm not sure, there are different names for it in different states. I do know that, but it was all voluntary. And so as part of our course, we had to sign up to be volunteers. We didn't have to be actively volunteering like on a weekly basis or a monthly basis, but we had to sign up as volunteers. Um, and so I actually, they do like, they'll set up programs where, even like, where like veterinarians will set up like a van or something like that, and they'll do like free health checks or they'll do like discounted spay and neutering. Trying to think of what else, vaccinations. Um, but they did a lot of like community outreach, things like that. One of the things that I did with the MRC was in some of the senior apartment complexes. Um, I would go once a month and we would do blood pressure checks. So I would do blood pressure checks. I would look at their glucose logs to see if they needed, any help with, managing their diabetes. And then of course, being that, as a nurse, I could just recommend that they follow up their healthcare provider, but it was kind of a means. A lot of them were, they didn't get out very often, didn't have a whole lot of family. So it was just one of the resources. So there are some health promotion programs that are out there. They also will respond to community health issues. So like, a disease outbreak. So at the time there was also a epidemiologist at the health department, and I'm not sure, and I think with fundings, um, I think I don't know if there's like an epidemiologist at like the local level or not. But she was, so she did a lot of things. Like, looking at the different areas, and looking at what are the more prevalent diseases. Like she did a real big study on adolescent obesity within one of the areas. But like then she was telling me how they had an outbreak of salmonella one time, like as a result of obviously undercooked chicken. I think it was after a wedding. So they will respond to community health issues. If they can't handle it by themselves, then they often will get help from other agencies as well. So then we have I made it big now, it doesn't want to stay. Each state also has a state health department, and that is funded by state tax money. It also may receive some subsidies from the federal government. Sorry. And then at the federal level, the official health agency is the U.S. Department of Health and Human Services. And so HHS has a lot of different responsibilities. It is a person that the head of the agency is a person that is appointed by the President of the United States. And they will advise the president on any health matters. It is also, I guess I have to make this bigger so you're smaller. So it is also funded by federal tax dollars. And it has 11 operating divisions. And 8 of those are in the U.S. Public Health Services. So under that, we have like the U.S. Food and Drug Administration. So what does the FDA do? Everybody's heard of the FDA at some point.
It
They're in charge of,
regulates the foods that we eat, so whether or not they're healthy or bad, or they have like chemicals and stuff.
they
Yep.
also regulate the immunizations and stuff that we take.
Yep. So your food, your medications, your immunizations, even medical devices, and some of the electronic products as well that emit radiation. So, like medical devices, your implants, like your hip replacements, your knee replacements, ankle replacements, your like internal defibrillators, your pacemakers. I mean, there's so many out there. I'm not going to name them all, but right, all of those medical devices they'll also have to be approved through the FDA. Um, and then we have the CDC, which is the Centers for Disease Control and Prevention. And it provides leadership in our health prevention and promotion programs. The CDC will also respond to public health emergencies, which, we heard a lot about the CDC during COVID, if anybody remembers that. We have the National Institutes of Health. So NIH, they fund biomedical research, and not only in its own labs, but also in universities, hospitals, some of your private research institutions, as well as other private industries. They also train new researchers. They promote the collecting and sharing of medical knowledge. And there's 27 institutes and centers that fall under the National Institute of Health. So it is a pretty big organization. I don't know why this still won't flip for me. Okay, whatever. And so then we have our voluntary or our non-official healthcare agencies. And so a lot of people have heard of these, whether or not, you've had to utilize them yourselves or even for, sending your, patients, but like the American Cancer Society. So American Cancer Society is, there for cancer research. It also provides information to clients as well as their families, as well as healthcare professionals. Our American Diabetes Association, they do resources for diabetic care. They also, your diabetics can go to the American Diabetic Association and they can look at like what are healthy food choices, right? How to kind of manage their diabetes. Lots of resources, lots of educational programs on that website. The American Lung Association, a lot of research, education, not only just for the professionals, but for the public as well. Then, of course, our American Heart Association, they provide research and education on heart disease and stroke. Alcoholics Anonymous, right? That is rehab help and support to both clients as well as families that are, dealing with alcohol addiction. So you have AA, you also have, now I can't remember what it's called. Um, it's a separate one for families. What is it? It's Alcoholics Anonymous is for the person that's in recovery. And then there's another part of it that is for like the family members.
Al-Anon.
Thank you. What is it again?
Al-Anon.
Al-Anon. I don't know why I can't. That's what I thought it was, but I was like, no, is that it? But thank you. Yes. We also have Narcotics Anonymous, right? Which is it's separate. It's, those dealing with more of your opioid use. La Leche League is information and support for breastfeeding mothers. I mean, there's a variety. There's more than just what is listed here on this slide, but there's lots of other, voluntary healthcare agencies that are out there that can provide some really good support services for people with that fall into those categories. Our private healthcare agencies, which, most of us are pretty, we're more familiar with these. These are either our proprietary, which are for profit, or our nonprofit organizations. They focus on curing disease and illness, as well as disease prevention and wellness. And most of us get our healthcare through private providers, right? So think of what some of the local hospitals that are in your area. They're usually big, most hospitals are like, I call them chains. They have more than one hospital. Majority of them are for profit. There are some that are nonprofit, like some of your, like I know, for example, our Children's Hospital was a nonprofit organization that relied a lot on donations in order to keep the hospitals going. What else? Private healthcare also will encourage your primary care. So primary care, right? That's usually where most of us will enter the wonderful the healthcare system. The family practice providers, they diagnose, they treat, they bill fee for service. They can be doctors, they can be nurse practitioners, physician's assistants, right? Whoever, excuse me, my voice, is, employed in there. Um, your and then we have private practice nurses that are your advanced practice nurses who may work in some of those rural areas where physicians are a little bit harder to obtain. They're it may be a little bit more, it'll be a little easier to see a private practice nurse than it would be to see a physician. A lot of people don't want to, think about people spending all that money on medical school. They don't want to spend a lot of time in those rural areas. They want to be in the bigger cities and the bigger hospitals. Um, and I remember doing a paper a long time ago for one of my nursing programs. I don't know if it was my bachelor's or my master's, but there was a program that the government offered um, for medical students that should they decide to go practice in a rural area, they would get what's it called? There were incentives for them to go and practice in the rural areas for a period of time. I don't remember what all the incentives are, but I think they were, it was pretty interesting that, they're trying to find providers that would go into those rural areas. Then we get into our types of hospitals. So they have community hospitals. We have our federal government. We have our non-federal psychiatric. So community hospitals are the community is in non-federal, short-term general and specialty hospital. So most of our community hospitals are short-term general hospitals that will provide a diverse range of medical services. Generally, we call these like acute care hospitals, right? So think of whatever area you're in, whatever hospital it is. You got to go to the emergency room for whatever reason, right? The hospital that you go to. Most of the time, these hospitals are able to accommodate to whatever it is we need. Should we go there? So again, there's a diverse range of medical services. They may not have the specialists with the expertise, though, for treating serious or unusual medical issues. Some of the hospitals may not also have the equipment, the lab facilities, right, for those serious issues as well. So there may, need to go to a specialty hospital, right, where the specialty hospitals will offer services related to that specific, condition or whatever. So what do you give me an example? Anybody know like what a specialty hospital would be?
One that specializes in like heart disease, like
Okay, a heart disease, like a heart center. Okay.
ENT,
Perfect. Say that again.
ENT,
Say that again.
ENT,
ENT. Okay. What else?
Like Shriners.
Shriners
cancer
is like children, right?
Yeah, it specializes in children with disabilities.
Mm-hmm.
and cancer.
Cancer treatment centers. There might be burn centers, right? Not every hospital has a burn center, so that might be another specialty. There's even trying to think of what it's called and I can't oh, what is it called? It's like rehab hospitals, right? Acute rehabs where um they need a higher level, like, okay, just for example, right? Some people go in, they get a hip replacement, they get a knee replacement. Sometimes they'll end up in like a skilled nursing facility, right? That's usually a part of a long-term care facility, right? So they get their PT, their OT, whatever it is that they need, then they go home. Some people qualify for a higher level of rehabilitation. So you might see that they go into a special rehab hospital, which is a little bit more intensive therapy to get them back to where they are. A lot of your stroke patients, if we get them into those like higher level rehabs, right, get them started more quickly, they tend to do a little bit better. Orthopedic hospitals, right? There might be, some hospitals have orthopedics floors, others do not. It really just kind of depends on where you're at, the needs of the community, and the availability of those resources that are within that area. We also have voluntary community hospitals. These are either community associations or religious organizations that operate these nonprofit. So Shriners would be considered. Another one would be like your St. Jude's Children's Research Hospital, right? That would be another one of the nonprofits. Especially, well, I know Shriners runs their commercials pretty much year round. St. Jude's has their telethons. You may hear them on the radio, or you may see them on the TV, looking for donations and gifts to supplement their income. Because if you know about Shriners or you know about St. Jude's, they don't charge the families for the services that are offered. So they rely on donations and gifts in order to supplement that. They do have a paid administrator, and they manage the hospital. But the ultimate responsibility there for the hospital is going to be with the board of trustees. And those board of trustees are usually voluntary. They don't get paid, but the administrator does get paid within that voluntary, those community hospitals. There are proprietary hospitals that you may see that also will fall under the community, which, they're going to be responsible to whoever their individual owner is. Then we have our federal or our state government hospitals. These are public hospitals. So these are going to include your VA or your Veterans Administration, your state, county, your municipally owned and operated nonprofit hospitals. It also is hospitals for people with serious mental illness, that, it's funded by federal, state, or county funds. Come on. Then we have teaching or research hospitals, both community hospitals and federal government hospitals can be teaching and research hospitals. Their goals are to treat clients that have serious or unusual conditions. They're also training sites for healthcare providers, nurses, and other healthcare professionals. They also look at research and developing new treatments for diseases, health promotion strategies for how to deliver low cost, high quality care. They do clinical trials. I don't know if anybody has heard them, but there's, you'll hear them in like, what do you call it, on the radio. They'll advertise for people that, have, certain conditions to see if they fit into, be a volunteer with some of the clinical trials. I don't know if anybody has ever heard them. But they're, some of the most common one that I've heard like recently is eczema and asthma. But there's always different ones out there. Most of the time, your teaching and research hospitals are affiliated with medical schools. So they do have better access to some highly skilled practitioners. So think of like Vanderbilt or Boston University. I'm trying to think of some of the Johns Hopkins, right? And there's more. Those are just some of the ones that kind of pop into my head, that they do a lot of research, a lot of training of providers. Our critical access hospitals. So critical access hospitals, these are very small. And so they're usually located in more of our rural areas. There's no more than 25 inpatient beds. They usually have a length of stay less than 96 hours. For acute inpatient, they still offer the 24-hour, 7-day-a-week emergency care as well. But again, they're located more in your rural areas, at least 35 miles from another hospital. And so they provide care for more common conditions. They also provide some outpatient care as well. And what they'll do is, let's say, I don't know, I think rural, let's say there's a farming accident, okay? What they can do is stabilize the patient, and then get them to, get them stable, and then transfer them to a larger health system to continue their care. I know it's not the most exciting stuff. I apologize. And then, outside of, the acute care hospitals, we do have our things like ambulatory services. And so ambulatory services may also be located in an outpatient hospital. It could be nursing care centers, it could be your HMOs. There's also community health clinics. The goal here is that ambulatory services offer less expensive care. We're not putting them in the hospital, so those costs aren't going to be as high. They come for assessment, treatment, care coordination, monitoring, I'm trying to think what else, evaluation. So some of your, ambulatory services could be, going to like an outpatient clinic. Outpatient clinics, it could be your, provider group. It's also going to include your urgent care centers. Trying to think what else. Even some of your nursing care centers, these are, would all kind of fall under your ambulatory settings. So your outpatient clinics, I will tell you, so, outpatient clinics, we think of, and I don't know, you guys are all in different areas, but, trying to think of one, like Med Express. Do you guys have Med Express? Anybody have Med Express? Yeah. Trying to think of what another one would be. Shoot. I can't even think of any of them anymore. But like urgent care centers, that are a little bit different. They're freestanding, and a little bit less of a wait than if you have to go to the emergency room, right? Um, I thought, when I was in Virginia, was just interesting. I mean, there was a few urgent care centers, you might be able to go to. When I moved down here, I will tell you, just within like a 3-mile radius, there's about 10 urgent care centers. Like, and they all advertise no wait. And I'm thinking, yeah, I wouldn't think there's a wait because there's so many. Like, you drive past one and it may be, you can just find one that's empty. And just, there's so many urgent care centers around here. It's just kind of crazy. But outpatient clinics can provide, follow-up care to patients after hospitalization. They help manage diseases for patients that don't need to be hospitalized. They can either be part of a healthcare system or they can be freestanding, which means that they're not attached to a hospital like MedExpress, right? MedExpress is not generally attached to a hospital system. It's a separate entity. You don't usually need an appointment. For the most part, you can walk in. And a lot of patients or a lot of people, not patients, but a lot of people use a lot of these outpatient clinics more as primary care, when they need something. They also may include your specialty areas, diabetes, neurology, allergy, oncology, dermatology. So it really depends. The number of specialized clinics, right? It's going to depend on the population and the medical needs within that population. And still will hire, nurses, medical assistants, obviously doctors, nurse practitioners, so variety of different healthcare team members. And we have your urgent care centers. Again, they provide services for walk-in clinics. And again, a lot of people use these as their, family, or, as their primary care. People that don't have a healthcare provider, can't find a healthcare provider, whatever the reason, they may use the urgent care center as their primary care. It's, more convenient too, if you think about it, right? If, I don't know, who's got kids? Raise your hand if you have kids. Kids don't get sick between 8 and 5, right? It's like your kids get sick after hours in the middle of the night, right? And so what do we end up having to do? We end up at the emergency care, the urgent care, right? And so these help, especially, in those after hours. Um, and so there's a variety, like I said, there's a variety of different ones out there, whether it's an urgent care, an express care, but they're, if you have insurance, they do accept insurance for the most part as well. Otherwise, it is usually going to be a fee for the services that you that you would need. Big thing with urgent cares or even with the quick care is educating our patients as to which ones are appropriate to go to, right? Because they're often not, attached to a major, to a hospital. If it's a life or death situation, making sure that they go to the emergency room, right, and not the urgent care. They may be able to stabilize them a little bit, but the goal is then going to be to get them to, right, the hospital. 1-day surgical care centers, or your ambulatory surgery centers. They do surgeries at a scheduled date and time. So if you need to have outpatient surgery, you may go to an outpatient surgery center or an ambulatory surgery center. They go in for their surgery, and then once you've recovered from anesthesia, right, you're stable, you get to go home. Some of your, so what does it do? It prevents the charges for being hospitalized overnight, because hospitalization's expensive. Most surgeries can be provided by or performed in an ambulatory surgical center, surgery center. However, if it is complex, or, an emergency surgery, or I'm trying to think of what else, for something where they may need to stay overnight after the surgery, they're not going to be in the 1-day surgery center. Sometimes hospitals, and again, depends on what your area is, they'll have two. They'll have an outpatient surgery center and an inpatient surgery center. So They have the same thing. You go in the morning, go in, get your surgery, you go home at the end of the day. The inpatient surgery, right? Those are usually, somebody that's is going to have surgery and is going to be required to stay in the hospital for whatever period of time afterwards. So it really just depends on what type of surgery that the person is having. Free clinics. So some communities have free or reduced fee clinics. It is for people that can't afford traditional health services, or, they're more reluctant to use traditional healthcare services. And most of the time with your free clinics, the cost or the charges are going to be based on income. So they may actually have an age limit or an income limit. One salaried administrator will staff it, and then the rest are usually volunteers. So volunteer healthcare providers as well as nurses. And they usually will have a volunteer board that makes the policy decisions for the clinic. I haven't looked down here to see what the availability of free clinics are. But I know back in Virginia, we only had like one or two free clinics, which was because of the lack of funding for a lot. And, having just the one clinic, it makes it more difficult for people to access those services. So imagine being homeless, right? And you're in one part of the city and, the free clinic is on the other side of the city. How are you going to get there to access those services? So it depends on the area. Some of your bigger cities, they may have more, right, free clinics that are available. And then we have skilled nursing care. So skilled nursing is usually provided, right, in long-term, usually part of a long-term care facility. It's, it's met in in order to have skilled care, it has to be medically necessary that will improve the quality of the client's health or to maintain or slow decompensation of a client's condition. So we'll talk about some skilled nursing needs. But what is a skilled nursing need? What makes it skilled need?
Improve your quality of care, like say
Okay,
if
so
you had a broken hip.
okay.
Yeah.
So it could be after a hip replacement, it could be after a knee replacement. It could even be after a trauma. Okay. Somebody has had a major trauma. Um, what
A
else?
stroke,
A stroke. Absolutely.
heart attack.
Mm-hmm. I
Okay.
was just gonna say anything dealing with rehabilitation.
Right. So with that, in order to receive skilled nursing care, they have to have a skilled need. Otherwise, it's not going to be covered, right? So maybe they require IVs, injections, wound care, complex wound care, respiratory support like oxygenation, whether it's O2 therapy, if they're on a trach, depending on their level of care with dementia as well. That could be a qualifying factor. But generally speaking, it's something to do with wound care, therapy, IVs, catheter care, respiratory therapy. So just keep that in mind with skilled care. And we look at alternatives to long-term care. I will say I'm getting older. Okay. My goal in life is not to enter a nursing home or a long-term care facility. Although I love working in them, I do not wish to be in one. Um, and so we want to look at what are some of the alternatives for people that are getting older that may need a little bit more assistance with care. Um, and so, want to live at home. They need, maybe need assistance, helping them to get some of their ADL. Excuse me. So sorry. We have home health services. So home health agencies can be public, they can be private. They provide home health services. They're generally supervised by a licensed health professional. Generally speaking, it's going to be by an RN, and then of course your, LPNs, your nursing assistants will also go in. Um, and so it differs, home health differs from hospital as well as long-term care, because there is an increased focus on relationship-centered care as well. So, not only are with home health are we building a relationship with the client, right? But we are also going to build that relationship with the family or other caregivers. We're going into somebody's home. So if you remember from community, we talked about home health and community as well, right? It's, we're going to someone else's home and we're looking at what are some of the safety concerns and other issues that may rise as a result of that. So some of the skilled services that we can provide at home would be skilled nursing, right? So if they need IV therapy, they need wound care, respiratory care, right? So we can provide the skilled nursing services. We can provide PT, OT, speech therapy. They also get they need medical social services. They also may need some homemaking assistance, which would be your home health aide. So way back in long time ago, right when I came out of high school, I started off as a home health aide. So we took, I forget how long the course was, but a lot of what we did was we were able to take vital signs, but if they needed to go to the grocery store and a doctor's appointment, we would also be able to assist with those services as well, helping them cook, clean. Um, we're also some services that could be provided by home health aides. Nutritional therapy, podiatry, I'm trying to think of what else. Respiratory therapy also may be provided by that. With those skilled nursing services, like I said, we were going to get back into that. These are provided and directed by the registered nurse. And then the basic nursing services are going to be provided by the LPNs, all right, under that RN supervision. And so depending on state regulations as well as agency policy, the LPNs are able to provide many of the home health services. But it's generally going to still be a coordination of care, right? There's still going to be an RN that is going to initiate that plan of care. So some of the things that, we'll do, teaching, supervising, administering, or preparing medications for self-administration. They give injections, check glucose levels, helping them create a nice, safe environment, right? Removing the clutter, the throw rugs, right? Trying to think of what else, like any extension cords, right? Making sure that there's handrails or grab bars in the bathrooms, right? So we want to ensure that safe, right, environment at home. Ostomy care, wound care, bowel and bladder training, oxygenation, respiratory care. Those would all fall under skilled nursing services. So again, in order to qualify for home health, you have to, sorry, my finger played with my mouse. They have to have a skilled need. So making sure that's what's going to help them keep those services. Other types of care, we have community health nursing services. The major goal of that is to improve the health status of communities or groups of people through education, screening for early detection of disease, and services for those outside of the acute care setting. Adult daycare centers. These are actually really cool. There's a big one in Virginia. It's called Gen Care. I don't know if anybody's ever heard of Gen Care. But they can be hospital based like PACE. Has anybody heard of PACE before? PACE is offered in I can't remember what it's program for. Oh, what is it called? PACE is the program of all-inclusive care for the elderly. Um, so anyway, so an adult daycare center, they provide services for those who need supervision, whether it's due to physical or safety needs. So let's say when I get older, I live in with one of my children and I'm not safe to be home by myself. They'll send me to an adult daycare center, okay, and I'll spend the day at the adult daycare center and then I'll go home at night with my family. All right. So it is for it's for clients that have families that assist the patients during the evening hours, but in the weekends, but are not there during the day. So there's a safe place for them to go. Some of them like the PACE program, it's providing mental stimulation, socialization. They also may get some assistance with ADLs, nice safe environment for that person to go to. Some of them, include transportation. So they may pick up your client in the morning and bring them home in the afternoon. They might provide meals, like breakfast and lunch. There's activities, there's nurses, there's rehab, and then some with the all-inclusive, there actually may be healthcare providers like doctors and nurse practitioners there as well. It just really kind of depends on the center itself. Independent living facilities, they don't provide healthcare delivery. It's like a senior living center or a senior living apartment complex, or some of them are like really resort style. Like I'd never be able to afford any of that, but some of them, can be pretty expensive, but they're living with, people within communities with people their own age. They do like plan trips and stuff like that. And they have like a nice little, apartment. Assisted living, is home with services. So they may have some assisted care. Um, they, want to stay independent, but they just can't handle all of their ADLs. So they do get help. They still have their own private, like little apartment type thing, that are handicapped accessible. And then, there is help that is available with some of their daily routines, but it's not like a 24-hour, home, like home health aide or something like that. Um, your continuing care retirement communities, these are actually pretty cool, and I've seen a couple of these. These have the different types of housing available. So they may have independent living apartments, they may have assisted living apartments, and then they may have a like long-term care or rehab type situation as well. So let's say, for example, you have a client that is in an independent living facility or independent living part of the community, and they fall and they break their hip. Okay, they can stay within that community, get their rehab, um, for their broken hip, and then they can go either back to the independent or maybe they need to go to more of an assisted living. Or the same, take a different client who is independent and maybe they have dementia. And as they start to decline, right, then we can move them into another level of care, right? So they can stay within the community, right? And just go from one area to the area, depending on what their needs are. So these offer some, pretty good, resources as well. But of course, we do have to take into consideration cost, because some of them can be very, very pricey. And then our rehab services. So rehab services, um, this is, working on returning to function, right? So following an acute illness or an injury, um, they'll go into need some sort of rehab. And it could be in your rehab centers, like I talked about earlier. It could be in your long-term care. They can do outpatient rehab. There's residential homes. And then, of course, there is home health, right? Depending on the person's ability or their needs, then they may get, home health available. And then we have our wellness centers. So wellness centers has a emphasis on promoting wellness, and detecting diseases in their early stages. So wellness center programs are things like nutritional counseling, exercise programs, stress management or stress reduction and weight control. So, this could be um, things like Weight Watchers, smoking cessation, stress management classes. It could even include parenting classes. So there's a variety of different things that fall under wellness programs. And then I didn't realize what time it was. I apologize. Let's go ahead and take a break. Be back at 4:10. All right, and then the last part of chapter 15 is hospice and palliative care. So who can tell me the difference between hospice care and palliative care?
You do palliative care all the time. Hospice is pretty much making them comfortable and not doing anything preventative to keep them from passing away, just to ensure their life is as end of life is as comfortable, just making them comfortable.
Very good,
And with
absolutely. So
palliative care, you don't have to be terminal.
very good. Perfect. Yes. So with palliative care, you don't have to be terminal. With hospice care, generally speaking, right, that we are considered terminal. So hospice, it's you've been certified as terminally ill. Generally speaking, you have 6 months or less to live. Um, if the disease runs its normal course. Now, I'm not saying that you can have that terminal diagnosis that you have 6 months live. Doesn't mean that you have to die within, by 6 months, no, not necessarily, right? Just normal progression of that disease would mean that, 6 months or less. Um, and the philosophy of hospice care is to maintain comfort as death approaches. So it's death with dignity. Um, Hospice can be offered in the hospital. It could be like a hospice house. It could also be offered at home. Um, And so it really kind of just depends. Then within the home, there may be RNs, LPNs, home health aides, CNAs, volunteers, chaplain services, case management services, even social services. So there's a variety of support that occurs as a result of hospice care. But again, it's right, they're terminally ill. With palliative care, it's providing comfort care. It is similar to hospice care. However, it's usually initiated at the onset of treatment and it can be accessed at any stage of illness, whether they're terminal or not. So it can be from diagnosis to cure. And so while receiving palliative care, they can still choose to receive life-saving treatments. Um, Not all palliative care is hospice. Hospice clients still receive palliative care, right? But we're just not with hospice care, we're not providing life-saving treatments. Um, so that's what the big difference is. The goal is to improve the quality of life, not just our clients, but of their family members as well, by relieving symptoms and stress of a serious or debilitating illness. So things like to help relieve symptoms of loss of appetite, pain, nausea, sleeplessness, providing help with healthcare decision making, as well as supporting, right, family members. So again, with hospice, we're not really providing life-saving treatments. With palliative care, we are usually, there are some life-saving treatments that may still be um, offered. So it's a little bit different. Um, one of the biggest things that I have learned since moving to Texas, which I had never seen before. So if you guys have, don't judge me. But I've never seen hospice patients that were full codes. Any other time that I have worked with a hospice patient prior, they've always been DNRs, right? But here, there are hospice patients that are full codes, and thought that was very interesting. And I guess in a way, didn't make sense to me. Um, but yeah,
My mom was full code in
you're,
hospice.
yeah.
Yeah, my mom.
So, okay. So I don't know. Because so, we look at the difference, and this is just me, this like what happened when she passed?
When she passed away, they actually, like, we called the paramedics came because they were supposed to come because she was full code. So they came and they did the CPR, and like she died 2 hours later, they were able to revive her. But we didn't want her to stay because she was brain dead already.
Mm-hmm.
That was really frightening. Like we all sat as a family and thought that was a mistake because we saw her came alive, but she had died for like 2 hours. She had passed away
Oh, wow.
for 2 hours before the paramedics came, and this is since she's full code, they can try to do something so they shock her and did all what they could do. She came back alive, but she was brain dead already. So they
Mm-hmm.
wanted to put her on life support, but we said no.
Mm-hmm.
Yeah.
Yeah. So that was just something that I had never been exposed to. Was, having a patient that was in hospice that was a full code. Um, and just it was a just it's a new it's something new for me that I've not experienced before. So if I was, I also down here too, which is interesting. They're so different, learning different, when you go from one area to another, just the way they do things. Um, I forgot what I was going to say now. Oh, if they are under hospice care for like if they have a specific diagnosis, then hospice only deals with that diagnosis. They don't deal with anything else that occurs with the patient. So I thought that was interesting because my prior experience with hospice, right? If a patient was on hospice, regardless of the reason, they received all their care through hospice. So down here, let's say they're on hospice care because they are like at end stage, dementia. Um, Anything that's not related to their dementia is still covered by their healthcare provider, not their hospice provider. So it's just a
Mhm.
whole different view, a whole different way of seeing things. So just, again, just interesting how, things are different from one area to the next. Which now we'll go into chapter 16. So chapter 16, we talked about in chapter 15, we talked about the different types of health or hospitals and healthcare systems. Um, how do we pay for it? So this is something that, and you ever had to go to the doctor, you realize that, we have to pay for the services that are provided. So chapter 16 is about healthcare financing. So when we talk about the US healthcare, everybody has their own opinions about the wonderful healthcare system in the United States. But it has been described as a poorly organized and complicated maze of services that lacks preventative care, waste resources, and is very expensive. And if anybody has ever used the healthcare system, you know that that can be very true. Um, and so we've, you know, every president, every leader, I think, has tried to step in and try to make the healthcare system a little bit better
Hey,
as we go. Um, and so, a lot of things have occurred. Um, and because of the cost and the waste and, the lack of preventative care, um, like I said, we've had to make some changes. Back in the 60s, the 1960s, the healthcare provider's key role in healthcare decision making combined with fee for service that contributed to making healthcare costs and just skyrocket. So then in 1980s, Medicare changed from a fee for service to something called a prospective payment system, which is based on DRGs, or what we call diagnostic related groups. And so hospitals were paid based on their DRG. Um, and so a big focus there with the DRGs was to minimize how long patients stayed in the hospital. And this kind of led to what we call utilization management. And at this time, too, the payment system extended to include healthcare provider payments, which led to developing managed care organizations. So managed care organizations are things like, I don't know if any, how many of you have different type, everybody has different types of health insurance plans, but these are like your HMOs, your PPOs, your health maintenance organizations, your preferred provider organizations, your point of service plans. There's also open access plans. Just depends on how you have your insurance, whether you get it through an employer, whether you get it through the private sector. There's a variety of these different plans that are available. And it really kind of just, like I said, it depends. Costs can be involved. So I don't know if anybody has ever had healthcare through an employer, but you'll do your like open enrollment every year, or like when you first get hired, you have to choose a health insurance plan. And they usually have different tiers that you can choose from, and you have to go and you have to look at all of the different costs that are involved, right, before you make that decision about how much you want to pay for your health insurance. And even with all of these different changes that occurred, only a small improvement in healthcare costs was realized. Still having high access or high medical bills. There's still a lot of inequities in our healthcare access, which we know not all Americans had access to healthcare, especially if they were underemployed or unemployed. The poor struggled with accessing care despite even having health coverage. And so, again, this is all kind of what led to us thinking that, American healthcare system just being broken. And in a lot of ways it was. In a lot of ways, honestly, it still is. But then we had the Affordable Care Act, right? This was previously known as Obamacare. It was established in 2010. Geez. It was the first sweeping piece of legislation to address healthcare reform in the US since 1965, when Medicare was added to the Social Security Act. So that's a really long time. And so the goal here, right, it was designed to enhance the access and affordability of healthcare, particularly to those citizens in financial need in the United States. And so it has decreased, excuse me, the number of uninsured in the United States. Has it completely eliminated the amount of uninsured? No. Like, we still have plenty of people that don't have health insurance. With that, the Affordable Care Act established the marketplace. It's a health insurance marketplace, and it's just a resource where people, families, even small businesses, can learn about their health coverage options, choose a plan, and enroll in coverage. It also provides information on programs to help people with low to moderate income and resources pay for their coverage. So it did help a lot of people get insurance. And then we have in 2017, what's it called? The American Healthcare Act was approved, but it was never enacted. The goal was for it to replace the Affordable Care Act, but it never got put into action. So we still have the wonderful Affordable Care Act. So with the Affordable Care Act, the Affordable Care Act, like I said, it did a lot for people. It did a lot to help. There's still, lots of change and reform that still needs to be made before we can have, a really good healthcare system. We have some great doctors. We obviously have wonderful nurses. We just need to find ways that everybody can access them. So we look at how do we finance healthcare costs? So this honestly, and yes, it's a little dry, but it's just really a lot of definitions. So fee for service. So fee for service is the traditional method of paying healthcare bills. So you have a sore throat, you go to the doctor, and the doctor, I don't know, runs a strep test, gives you an exam, and they charge you whatever it is. Okay, that's your fee for service. So the healthcare providers are paid a fee for each service that they provide. The physicians are directly reimbursed for most ordered tests and treatments. Some insurance companies don't reimburse for preventative or diagnostic tests for early stage diseases, which to me, or early stage illnesses, which is a little crazy. But capitation, on the other hand, is the healthcare provider will receive a fee per member over a designated time frame. So let's say you have, I don't know, you have an insurance. The insurance company is the name of your insurance, okay? So they're providers that accept the insurance company. All right, they get a monthly fee for each member that has the insurance as their insurance company. All right, and so that provider will get, I'm just going to say $25. So for every person that has the insurance, okay, that provider is going to get $25 per month for that person, or for, whatever amount of time it is. And so they have that money whether or not that person uses those healthcare services or not. So kind of think of it as, I always think of this one as like your car insurance, right? You pay your car insurance every month. Some people never use their car insurance, right? And then there's other people that use their car insurance often, all right? So the ones that don't use their car insurance are paying for the ones that use it, right? Does that make sense? So they're getting this money. And so let's say, that $25 and you go to the doctor, and like I said, you got a sore throat and he runs a strep test, and let's say the total cost is $30, okay? That $5, the provider absorbs that cost, okay? So they don't get that extra $5. The goal, right, is if we keep our members healthy, then the providers will make a profit, right? So it's kind of like I said, you pay that car insurance if you never use it, right? You're just paying to have it. It's the same kind of system, right? You're paying for the services, but the goal is to not really have to use them, right? Because if you stay healthy or you keep your car up to date on its maintenance, right, don't have to use it. Sorry. Other ways that we pay for healthcare services, personal payment. And that's your private pay. So you go to the doctor, you get your strep test, you get your exam, and you go to check out, you just pay for the services that you incurred that day. And that was before the 1940s. That was the primary way people paid for healthcare services. Now, I don't even want to know how much it would cost to go to the doctor just to get a strep test. But so healthcare services, right? A lot of people can't afford just to pay for those services out of pocket. So that leads us to our health insurance. So we have private group health insurance. So it pools the individual contributions for a common group goal. It's offered by most employers in the United States. Before implementation of the Affordable Care Act, a lot of people couldn't afford healthcare insurance. So again, the American Health or the Affordable Care Act has definitely improved process. The Affordable Care Act also imposes penalties for larger employers that don't provide insurance. So I don't remember exact numbers, so I apologize for that. But companies under a certain amount of employees are not required to offer insurance for their employees. I think it's less than 50, but I could be wrong with that number, so don't hold me to that. But so if those bigger companies don't provide insurance to their employees, then there will be penalties for those employers. Smaller companies that offer insurance, I do know that they will get a tax credit. Okay, because it can be expensive to offer insurance to your employees. Your private individual health insurance is offered by some insurance companies to those that are not part of a group. So let's say, for example, we'll just use like Blue Cross Blue Shield, or I like United Healthcare. So we'll stick with United Healthcare. Okay. So United Healthcare, your employer offers United Healthcare and you get to choose a plan. That would be your group health insurance. Well, let's say you got laid off or you get furloughed or you quit. United Healthcare, maybe even Blue Cross Blue Shield, whatever, they may offer a individual group and individual health insurance as well. So you don't have health insurance, you may be able to contact them to see if you can get individual health insurance. I don't know what the cost would be, but it's usually based off of their health risk, their age, right? Do they smoke? That's a big one. Tobacco usage is a big one with, cost of health insurance. Okay. So let's get into these wonderful health insurance terms. All right. So premiums. Premium is your monthly fee that you have to pay just to have your health insurance. It's just like when you pay your car insurance, okay? That's the set fee that you have to pay. You pay them every month. They send you a little card that says you have their health insurance. A deductible is the yearly amount an insured person must spend out of pocket for services before the health insurance policy will begin to pay its share. So this is really important because when you are looking at your health insurance options, when you go to, when you get your, job as a nurse, or if you've not ever had health insurance before through an organization, this is something you want to look at. How much money on top of your premium that you're paying every month do you have to spend before your insurance kicks in? A lot of them are like $2,000, $3,000 that you have to spend before they start. Okay, so knowing what your deductible is really important. Your copayment is how much you have to spend when you go to the doctor. So maybe it's $25 for an office visit. Sorry. Maybe it's $50 for a specialist visit. Maybe it's $200 for an emergency room visit. All right, that's another thing that you want to look at. Okay, well, how much do I have to spend when I go to the doctor? How much do I have to spend when I pick up a prescription? Okay, because we know prescriptions can be very expensive. So looking at that. And then co-insurance, once your deductible is met, so you've met that $3,000 for the year, okay, you still may have a percentage of the bill that you need to pay regardless. So that's another thing that you want to look at as well. So even though you met your deductible for the year, after that deductible is met, you still may have some out-of-pocket costs related to your insurance. So again, when you're looking at these things, these are some of the things that you want to look at because, if, you want to go and I'm just giving an example. You say, oh, I just want to go with the cheapest insurance plan so I don't have to take a huge chunk out of my paycheck. But your deductible may be $5,000. And if you're not someone that goes to the doctor very often, you may never meet your $5,000 deductible. So you're paying a lot of out of pocket, right? So you kind of have to look at it really closely when you are choosing your health insurance. With public health insurance, we have Medicare, Medicaid, and Veterans Health Administration. So Veterans Health Administration, that's comprehensive care to all veterans. And so they have hospitals, they have outpatient clinics, they have nursing homes, they have home health. They offer respite care. So there's a lot of services that are offered for for veterans. But then we get into wonderful Medicare and Medicaid. So we'll start with Medicare. So Medicare was added to the Social Security Act back in 1965. It is a federally sponsored entitlement program and public health insurance that helps provide or helps finance healthcare for all persons over the age of 65, as well as their spouses, who have at least a 10-year record in Medicare covered employment and are a citizen or permanent resident of the United States. So, in order to receive Medicare, when you get to be 65, you have to pay into it for at least 10 years. Coverage is also given to certain younger people with disabilities and those with end-stage renal disease. So patients that have ESRD, especially if they're on dialysis, they are eligible to receive Medicare as well. No person is denied coverage based on past medical history. All right, so no matter what your past medical history is, you cannot be denied Medicare as long as you have paid into it for 10 years and are a citizen or permanent resident of the United States. Oops. So under Medicare, there are different plans, okay? So Part A is your hospital insurance. It covers your hospital stays, your care in a skilled nursing facility, hospice care. It also may cover some home health care. All right. So again, Part A is your inpatient hospital, your skilled nursing facility, your hospice care, and some home health care. Part B is what we would call your medical insurance. So this covers certain healthcare provider services, outpatient care, medical supplies, preventative services. Feel like I'm missing something. So Part B would also cover um, like your ER visits, mental health services, labs, x-rays, CT scans, MRIs, all that good stuff. Ambulance transportation would be covered under Part B. Durable medical equipment would be covered under Part B. Ambulance, I said ambulance, durable medical equipment. I'm trying to think what else. If they're the ESRD patients, their kidney supplies, some diabetic supplies are covered under Part B. PT, OT, speech therapy, either help outpatient or in a rehab facility. Trying to think of what else. But Part B doesn't pay for medications, dental care, dentures, foot care, hearing aids, eye exams, glasses, any of that stuff. So got to really look at it. Part C is your Medicare Advantage programs. So Medicare Advantage programs are offered by private insurance companies that kind of contract with Medicare. This can be your HMOs, your PPOs, your fee for service. I'm trying to think what else. They offer prescription drug coverage as well. Part C has to be paid for separately, so it is another out-of-pocket cost. And then Part D is Medicare drug coverage or prescription drug coverage. And so it, again, this one's offered by other insurance companies. So the only one that we're guaranteed is Part A. All right, so Parts B, Part C, Part D are all additional out-of-pocket costs for that person. Trying to think of what else. Oh, Medigap. So Medicare supplemental coverage, or what we call Medigap coverage. So it's supplemental insurance that covers things that Medicare does not cover. So it may cover some of those copays, some of the deductibles, that co-insurance. So that is another option. Again, this one is sold by private insurance companies. You may hear a lot about this right now on the radio, on TV, because it is the yearly enrollment for Medicare. So there's like lots of commercials about, helping to determine, what kind of coverage you need and what kind of plan that you need. So it's, I'm not even there yet and I'm already confused and I'm like, there's just too many people trying to talk too much and say too much. So it's kind of hard to like really figure out what's going on. Then we have Medicaid. All right, so it's still run by Centers for Medicare and Medicaid Services. It was also added to the Social Security Act back in 1965. And this program provides medical assistance for eligible families and individuals with low income and resources. So they have to meet those eligibility requirements. It is a cooperative venture, so it's funded not only by the state, but it is also funded by the federal government. So state runs their Medicaid program, but they do get some funding from the federal government. So each state, again, establishes its own services and requirements, including eligibility. And so like if you're eligible for Medicaid in one state does not necessarily mean you're going to be eligible for Medicaid in another state. So that is one thing to take into consideration. Undocumented immigrants and legal immigrants who have not resided in the US for 5 years are not eligible. So they have to be here for at least 5 years in order to be eligible. Trying to think what else. Then we have SHIP, which is another really great program. So this is the Children's Health Insurance Program. It is under Medicaid. It provides medical assistance for eligible children. So it covers uninsured children up, like whatever the income requirements are. And it's free or low cost health insurance for kids up to age 19. Oops. So we already talked about the cost of health insurance is crazy. There's annual increases in health insurance premiums for employers, which generally means there's going to be an increase in the premiums for us as the ones that have to pay those, our parts of the premium every month as well. The Affordable Care Act requires the federal government to create a process in conjunction with the states where insurers have to justify any unreasonable premium increases. So if they, or one of you, if your health insurance wants to, increase your rates, significantly, they do have to justify why they're increasing the rates as high as they are. So we'll talk about the uninsured next. So again, still have a large percentage of people here in the United States that do not have health insurance or affordable health care. And so the uninsured often include our low wage employees. So low wage jobs, they are less likely to offer insurance benefits. And even in some cases, even if it is a low wage job, the cost of their healthcare premiums could be extremely high, which would lead to them not being able to afford it. The middle class workers, some of these workers may be unemployed, and those employed may be priced out of the healthcare insurance market, right? Just because of those premiums that are going up. So alternatives. So back in 2014, as a result of the Affordable Care Act, citizens and legal residents were required to obtain health insurance or pay a penalty. I don't know if anybody remembers that. But we eliminated that as of 2019. And because think about it, and I actually had people that I knew who had tried to get health insurance through the Affordable Care Act, but couldn't afford the premiums. And so they did the math and they were like, well, the penalty at the end of the year was actually cheaper than the premiums. So they just opted to, pay the penalty at the end of the year, which, that was a choice that they had to make. And so, looking at the uninsured or even the uninsured, again, we don't have access to healthcare. We don't get preventative care, right? We're not getting our immunizations. We're not getting our mammograms, our pap smears, our prostate exams. And we know that early detection, right, leads to early treatment, leads to better outcomes. And if we're not getting that, then those, we find diseases in their later stages, which can have more detrimental outcomes. A lot of people in the uninsured area, like I was saying earlier, when we talked about the different healthcare systems, they, rely on the emergency rooms or the urgent care because they don't have a primary care provider or they don't have insurance. And so, they are using those urgent cares and they're using the emergency rooms. But how expensive is that? And I understand it 100%, right? I understand it because if you don't have health insurance and you go to the doctor, you're going to go wherever it is you can go. But think of the cost involved, between getting a strep throat at a doctor's or getting a strep test at a doctor's office versus going to the emergency room and getting that same strep test, right? The cost is, astronomical compared to using a healthcare, a primary care provider. Um, but again, if we still don't have health insurance coverage, right? And, we don't have a primary health care provider, people are going to do what they need to do in order to get the care that they need, right? So again, this is going to be some more definitions and things. So we have prospective payment system. And we talked about DRGs and we'll talk about prospective payment system or PPS. So PPS is a system of reimbursement that pays a predetermined fixed amount per patient admission, regardless of the actual cost to provide the care. So it's based off of that DRG. All right. So the federal government is going to the federal government is announces to the hospital in advance what it will pay for healthcare costs. So let's say you have a patient that has a heart attack. All right. So the insurance is going to say, here's, $5,000 to care for that patient that had a heart attack. So if you know that you only have $5,000 to pay for this person that has a heart attack, right? It helps to encourage hospitals to control costs, right? So you're not saying that we're going to cut corners, okay? We're going to just be careful with the care that we're providing. The problem with this system is, well, right, is it may cause somebody to be discharged from the hospital before they're ready to get discharged. It also can result in a decrease in quality of care, right? Because we're just trying to kind of treat you and get you, out, right? So that we can make some money off of, the care that, the reimbursement that we're receiving. So there are some issues that are going to fall into this. With that, we have our DRGs. And DRGs, like I said, diagnostic readiness or diagnostic related groups. We talked about them a little bit earlier. This is the government's attempt to stop the skyrocketing cost of healthcare. And so again, just like we said with the prospective payment system, that PPS system is based off of the DRGs. So and a math formula is used to arrive at a fee the government's going to pay for hospitalization. So like I said, that $5,000 to take care of that heart attack patient, okay? You're going to know this is what you're going to get. You're going to get $5,000 to take care of that patient, and you have to be able to take care of that patient for that $5,000. So hospitals receive a flat fee for each DRG category, regardless of length of stay in the hospital. All right. So that's where that incentive comes in to treat the clients and discharge them as quickly as possible. Right. So if you're only getting $5,000, and a night in the hospital is $1,000, right? We don't want to keep them in there for the full 5 nights. We want to try to treat them and, send them home or, somewhere else. So you can see where this can be an issue, right? And there are other, when we talk about healthcare, one of the biggest things is now it has gotten to the point where we're looking more so at the quality of the care versus the quantity of care, right? You can go into a patient's room 50 times a day, right? And if that client is not satisfied, right, then we get dinged for the quality of the care that we provided, not the
Yes,
quantity.
I'm at the Airbnb in Claxton's room.
Say that again. I didn't hear you, Jordan.
I wasn't talking to you. I'm sorry.
Okay. So we have to really focus on the quality of the care that we are providing. So that brings us to quality, safety, and the cost of our healthcare. So we look at quality and safety. So according to CMS, which is your Centers for Medicare and Medicaid Services, um, trillions and trillions of dollars are spent on healthcare. And so what do you think, as future nurses, what do you think are some of the reasons why healthcare costs keep rising?
Because a lot of people are not getting preventive care.
People not getting preventive care. That's a
They're
really good
coming
one.
in sicker.
They're coming in sicker. What else? We can throw the word greed, right?
Greed. Did you say?
Greed. Well, look at some of the pharmaceutical companies
Oh,
and
yeah.
the prices of
Yeah,
prescription
$1,000
medication.
for Majura.
Some of those medications are absolutely ridiculous, right? And they're needed medications. They're life-saving medications that people need.
Yeah, like
Malpractice law.
diabetes medications.
Oh
I
yeah.
didn't realize how much people say their medication costs. Their
Oh yeah.
insulin.
Insulin is ridiculous. It is absolutely ridiculous. It's so expensive. Medical malpractice lawsuits is another thing too, that leads to increased costs. And of course, technology. I mean, those MRI machines, those CT scans, the PET scan machine, they're not cheap. They're expensive, right? And so lots of reasons. But the US has the highest healthcare spending of all industrialized countries. So, but we also have lower life expectancy and higher infant and maternal mortality than a lot of our other industrialized countries in the world. So it's kind of interesting, right? Um, so with that, so we have the Institute of Medicine was we it's a program that is out there. It's a nonprofit organization. It serves to advise on ways to improve our health, our nation's health, looking at, do performing research and all that wonderful stuff. And I don't know how many have heard this, and I know it's not on the slide. But there was a report that was written back in 1999. It was called To Err is Human. And so it was like I said, it was a report. It was back in 1999. And it found that 98,000 people died each year from preventable medical errors. 98,000, and granted, this was in 1999. 98,000 people died from preventable medical errors. And it wasn't just like it was medication errors, it was wrong site surgeries, right? There was a variety of things like that that occurred. And so it also gave a strategy to prevent errors from occurring. So things like the safety timeouts and the ORs, And I don't know, like some of you, if you've like been in the hospitals and like at the Pyxis machines, there's like I always say caution tape, and it's not caution tape, but there's like tape on the floor in front of the Pyxis machines. Technically, if a nurse is at that Pyxis machine and they're pulling medications, they're not supposed to be disturbed. That's why a lot of your Pyxis medication machine or your Pyxis machines now are in locked med rooms, right? So that there's no disturbance. Um, they did, however, do, and I can't remember what year it was. I want to say it was 2019 because I think it was 20 years later. They did a follow-up study to see if any of those implementations made any kind of a difference. And there was still not a significant improvement in the people that were dying or being permanently injured through medical errors. So when we push things like the 9 rates on medication administration and the 3 checks and all of that stuff, right? This is our way of being like, this is why we're doing what we're doing. And by the number of messages that I'm getting, I do need to give you guys a break. So be back at 5:10. All right, so we'll go ahead and finish up chapter 16. So improving healthcare or improving quality in healthcare. So nursing action to improve quality in healthcare. Um, excuse me. So we had the continuous quality improvement, or CQI. Is one of the ways that we can help to improve. CQI, or continuous quality improvement, is quality by inspecting client incidences of harm or mistakes after they occurred. So if there's an incident that occurs, we kind of look at it, and we can identify some of the reasons why those, incidents occurred and try to prevent problems or future adverse events from occurring. Um, Other things, we have improving safety, which would be the National Patient Safety Goals from the Joint Commission. And so that as nurses, we've always taught you safety first, right? From day one in nursing school, it's always been safety, right? It's also do no harm. So Joint Commission will actually review incidents of serious harm and death to clients. And so again, remember that I told you about that 1999 study, right? So we have the National Patient Safety Foundation as well. That was created. To build a system of safety across the continuum of care. They partner with clients as well as families, the community, to improve client safety by avoiding those errors of commission or those errors of omission, or even doing the right thing the wrong way. And then we have the transition to practice, which was actually, it's a really great idea. This was an initiative by the National Council of State Boards of Nursing. It's aimed at improving the quality and safety of healthcare by new grads. As new grads transition into the healthcare system. And it's, a model that acute care settings use. It's 9 to 12 month program to help new grads, into practice. Generally using, they do classes, they have preceptors. There's a variety of different parts of that program. And it's, I've known quite a few like former students that have gone through these like transition to practice programs. And it's really kind of, it really has helped. And the national patient safety goals, I know that, that's another thing that I don't know how many people kind of remember those national patient safety goals. But it's, some of those like, using the two identifiers when you're identifying your clients, using medication safely, using alarms safely, preventing infections like your catheter associated UTIs, your ventilator assisted pneumonias, things like that. Same thing within like the home care environment, helping them prevent from falling, identifying those safety risks within the home health or the home care environment. And so think of like some of those things that, I said, oops, where'd it go? When we talked about research, right? How do we improve? So have that questioning attitude, right? What are some things that, as new nurses that you go out and you see in practice that you think that can be improved upon, and call attention to them. Other things with quality improvement, payments and penalties. which will always be, an issue. The pay for performance and never events align payment with client outcomes. So the pay for performance rewards hospitals that for meeting and exceeding standards of care for some of those high cost diseases like diabetes, heart attacks, pneumonia, heart failure. Again, like I said earlier, it's more about the quality of the care versus the quantity of care. Again, if you can go into that client's room 50 times, but if they don't feel like they're getting quality care, that's going to reduce your reimbursement. Also think about it, these never events. I don't know has anybody heard of never events before? What are never events? I know it's on the slide, but so never events are serious and highly preventable events. So your catheter associated infections, your ventilator assisted pneumonias, your pressure areas. It could be injuries from a fall that they took. Hospitals don't get reimbursed for never events. So let's say you are taking care of a patient in the hospital and they develop a catheter associated urinary tract infection. The hospital is not going to get reimbursed for that CAUTI. All right, the hospital is going to have to eat the cost for treatment of that. If they fall and they break a hip while in the hospital, same thing. The hospital is not going to get reimbursed for care of that broken hip. Same thing for that pressure area. Okay, so if a never event occurs, then that hospital is not going to get reimbursed for that care. So that is, one of the pushes, right, is to prevent those things from occurring. So aims of the Institute of Medicine: avoid injuries to clients from the care that is intended to help them, reduce waste and sometimes harmful delays for both those who receive and who give care, provide services based on scientific knowledge to all who can benefit and refrain from providing services to those not likely to benefit, avoid waste of equipment, supplies, ideas, and energy. Provide care that does not vary in quality because of personal characteristics such as gender, ethnicity, and socioeconomic status. And then always provide that patient-centered care, respectful and responsive to individual client preferences, needs, and values. Talked about those. Talked about that. Look at that. Long-term care national patient safety goals. I did not talk about those. So national or long-term care national patient safety goals, improving resident identification, improving safety of using medications, reducing the risk of healthcare associated infections, reducing the risk of resident harm resulting from falls, healthcare associated pressure ulcer reduction as well. And I'm gonna stop sharing because this is just interesting for me. So anybody work in long-term care now as a CNA who works in long-term care? Anybody? So I'm old, okay? I never denied that. Back when I first started in long-term care, we had side rails, we had bed alarms, we had Jerry loungers, right? We had all these things, chair alarms. What else did we have? I think probably still had like vest restraints and stuff, though we didn't use any of that. And they've taken all that away from us, right? You go to the hospital, what happens? They put you in a bed, they put the bed alarm on, they put the side rails up, right? And if you have to get up to go to the bathroom, your bed alarm goes off, right? And the whole world comes running. Well, long-term care is their home, right? So it needs to be a more home-like environment. So they've taken all of that away. So reducing the risk of resident harm resulting from falls. basically residents have the right to fall, right? That's basically what that is saying when you've taken our side rails, our alarms, all of that stuff away from us. So being very creative with your fall reduction, right? How do we prevent falls from occurring? And, we know all the traditional, if more frequent rounding, making sure they're clean, they're dry, all of that stuff. But it is a huge issue in long-term care. Not saying that people don't fall in the hospitals, because we do know that they fall in the hospital as well. Healthcare associated pressure ulcers. This is another big thing. And I don't remember what year this started. I mean, I told you there was a bigger emphasis on quality of care versus quantity of care. If a pressure area is found at a stage 3 or higher, it's a $10,000 per day fine, okay, from per incident. So let's say you have 3 residents that you found a stage 3 in one day. That's $30,000 per day from the discovery to healed. So how long do we know it can take stage 3? A really long time. To heal a stage 3, right? So imagine $10,000 per day from time that it is discovered till it is healed. That's a huge chunk of money, right? So this is why we have such a focus on trying to prevent these things, or even recognizing them early. With your hospital. I talked about the national patient safety goals. So what are some things as a future LPN that you can do to help to contain costs while you are practicing? What are some things that you can do?
Turn the
Make
patient every 2
good,
hours.
practice good hygiene for your residents.
Good
Make sure they're
hygiene.
clean and dry. Make sure you're checking the bony permanences to make sure they're not having any skin breakdown.
Okay,
And make
perfect.
sure they well hydrated.
Well hydrated. Very good. What
Good
else?
nutrition.
Good nutrition. So think of this too, and those are all excellent. So think on one something else that I know this may not, and you're looking at the big picture, and I love it. But let's look a little bit look a little bit lower. What about if you bring supplies into one resident's room, can you bring them out and use them for somebody else?
No,
No.
Right?
Like sterile technique.
Right. So let's say you have to do a dressing change. All right. And you grab a big handful of 4x4s and a big bottle of saline and I don't know, a whole roll of tape, just kind of going a little bit out there. Once you bring that into that person's room, that client's room, you can't bring them back out.
You can set it up for them for the next time you're going to do a dressing change.
What if they
To
get
kind of,
discharged?
well, you done messed up.
And
You
you
should
done
have
throw
told
it
us
in the
that kid
trash.
what you
Right.
need.
yeah, so we could save on cost effectiveness.
Yep. So think about the little things. It's just even like if you were to go in and, you had to do a linen change in a resident's room and you brought in like 5 sheets with you for whatever. I'm just, throwing something out there that's kind of crazy. You can't bring those sheets out and use them for Mr. Smith next door, right? Those sheets have to stay in that resident's room now. It's just like your wipes, it's your briefs. It's everything, right? Once it's in that client's room, it's that client's. So we need to be very, we have to be mindful of that. And I know a lot of times we think, oh, it's just a brief, or it's just wipes, or it's just some 4x4s. But if everybody had that same attitude, right, then, right, that's where our costs go up. So think about this, just think about those little things that as you're doing them, I'm not saying skimp on your residents or your clients at all. I mean, I'm all for giving them everything, but we do have to be mindful of the supplies that we are using. It's same thing with our time, you know. Um, if you've not worked in healthcare before, time management is a skill that you will need to develop if you have not developed it. Um, and I talked about quality versus quantity of care. Just because you're in and out of a room 500 times a day does not mean that you're providing quality of care, right? So you want to be very efficient, you want to be very effective in providing that care, as well as building that relationship with your client. Um, so those are just some things to kind of deal, how to deal with, or not to deal with, to kind of keep in the back of your mind as you start to transition into practice. And, um, like I said, I'm all for providing great patient care. Sometimes, we may have to use extra supplies, and I'm not saying that either, but just be mindful. If it's a small wound, you don't need, 20, 4x4s to go in there, or, 3 different dressings. We sometimes, we underestimate the size, which I've done. I've done. Um, and so you kind of want to, my best thing is go and assess first, and then look and see what you have to do, and then go grab your supplies. Another thing too is making sure that you're charging, especially in the hospitals. A lot of the supplies are through Pixis, right? So you have to charge the supplies to the client, to the client's room, and just making sure that you're appropriately doing that, and that you're not like wasting, them, and whatever you charge to that client, make sure that you're using on that client. All right, I can't keep you any longer. However, just real quick before everybody just jumps off, don't forget exam review is on Sunday. Okay, test is next week, and we will do a HESI review after next week's test.
You
So
said, you said the exam review is on Saturday? I missed
on
that.
Sunday,
On
Sunday
Sunday.
evening, Sunday evening,
Okay.
8 o'clock, right?
8 o'clock. Okay.
All right. Do you guys have an awesome weekend?
You too. Thank you.
Thank you.
Thank you.
Miss Martinez, was our meeting